Hi, my name is Joseph Irizarry, and I'm going to be going through a shoulder evaluation video today with you. And we have a patient coming into the clinic today, so we're going to walk you through the steps of that. So, what's your name?
Say again?
What's your name?
Mr. Bean.
Mr. Bean?
You call me Beans.
Beans? Okay, what's your first name, Beans?
Richard.
Richard? Okay. So, tell me what's going on.
I was out of practice and I was trying to, I'm a lineman, so I was trying to block the defender. And he's a little bit bigger, a little bit faster than me, so he stepped around me a little bit faster than I thought. And I kind of reached out to catch him and caught my arm, and I just felt this really loud pop, and I just can't move my shoulder. It hurts.
Okay, so it would be safe to say that your arm was kind of pushed back in that kind of position right there?
Mm-hmm.
Okay. And this happened just now. Have you had any prior injury history to the shoulder or anything else?
No, just bumps and bruises.
Just bumps and bruises, okay. So this is your first kind of big injury that you suffered before?
Yeah.
All right,
yeah,
so,
upper extremity wise.
Alright, so on a scale of 1 to 10, 10 being I got to take you to the hospital right now, what would you rate the pain?
8.
8? It's an 8, okay. And how would you describe the pain? Is it sharp? Is it dull?
It's kind of a sharp. It's almost kind of like a numbing pain. Something doesn't feel right.
Okay, so you say numbing. Do you feel anything like loss of sensation in your arm? Anything like that?
No, not really.
Okay, does the pain stick to the shoulder, or does it radiate anywhere else?
Mainly the shoulder.
Just mainly in the shoulder. Okay. And so I'm just going to do a couple of tests, kind of do some palpations. Is that okay? To start my palpations, I'm going to kind of go a couple things through. Start from the clavicle, kind of work towards where the injury is. I'm going to do some palpations. Is that okay?
Mm-hmm.
Okay. So we're going to start up with the sternum on the SC joint there. We're just going to go out here. Any pain with that?
No, not too bad.
Anything?
To get a little closer, it's just to get a little irritating, but it's not like the pain that from other places.
Okay. So I'm just kind of looking to see if there's any secondary injuries that could have occurred during the blocking drill itself, anything to the SC joint, AC joint. Obviously, I thought there would not be this much pain or discomfort here, which there was not, and as I got more towards the actual acromion and the shoulder joint itself, there was more discomfort, which is where the injury site is, which is what was to be expected. But I'm just trying to kind of look at to rule out any other secondary injuries that would be, obviously kind of behind the actual anterior shoulder dislocation itself. I'm just going to start off, I want to just double check and make sure that there's nothing wrong distally to the shoulder. So can you feel that?
Yeah.
Okay. Just going to check capillary refill, make sure the circulation's okay. Check brachial pulse, that's fine. Okay, so that's the good thing there, that there's nothing compromised distally to the shoulder itself. Now, looking at the unaffected side to the affected side, so kind of going right here, there's going underneath, so there's underneath the shoulder blade, there's a palpation, there's a deformity there. So it feels like the humeral head has shifted anteriorly. I will just kind of confirm that just to make sure there's nothing, with this particular individual that maybe that might be normal for them. And compared bilaterally, so this is a true deformity. So looking at how the humerus is shifted and the mechanism of injury with the arm being abducted and externally rotated going through the blocking drill, I'm looking at a anterior shoulder dislocation. Because of this, that's why I want to also check sensation, circulation, pulse, distal to the injury, but because of that we're not going to do range of motion testing, we're not going to do special testing because we don't want to do anything that's going to possibly cause further damage to the shoulder joint itself. We don't want to do any damage to the blood vessels, nerves, bones, anything like that. So what I'm going to look at now is the offensive lineman has his arm pretty close to the body, which is kind of ideal. So what we're going to do is we're going to splint and then refer to a position, and because of the position that he's in right now, it's really easy. I would just take an A-strap, go around, and just kind of make sure that's locked against the body. That way the shoulder won't move. They'll be stabilized. We can get him into see a position. Basically, what we're going through after that is really what the physician tells us, because setting up long-term treatment plans, short-term treatment plans for that matter, is based off of what they say, because we don't know if there's any more structural damage from that point on in terms of ligaments, muscles, nerves, anything like that. They'll probably get an MRI, maybe check an X-ray as well. They'll rule out any possible fractures that may be present that we can't see. So we're going to go from there, and we'll get the results back from the physician, and we'll come up with a rehab plan. But even after that, we're going to look into strengthening the shoulder. But first, we're going to start doing some basic range of motion exercises to get that back, and then we work on getting strength back as well. And that's kind of the natural progression. It's going through getting range of motion back, and then working on getting strength and getting back to where the strength was before the injury occurred. So that way they can perform at a, not just at a, just to protect themselves, but also perform at a high level to do what they can do not just for football, but for everyday activity.